Thank you. So today I'm going to focus on moderate to severe IBD, and particularly the anti-TNFs biologically and the immune modulators. So the key points, I think, are anti-TNFs are amongst the most effective therapies we have to treat patients, and one of the key things we have to do is select the appropriate patients. So I'm going to review these aspects of care that are likely well known to many, but certainly some may not know. We'll identify the risks and safety factors that we use in advance of treatment and the adverse events that are preventable in an effort to lessen these occurring, and optimize the therapies we use. Immune modulators, we'll talk about their particular role and how we currently use them. So the first thing to discuss is indication and drug selection. And this is dependent upon several factors. Do we have Crohn's disease or ulcerative colitis? What is the age of the patient? The severity of the flare? Is it a hospitalized patient or an outpatient? For example, with infliximab, we have good data for hospitalized patients. A subcutaneously administered agent has not been as well studied. Were the patients refractory to conventional agents? If so, which medications were used in prior treatments? Do they have fistulizing disease? Are there extraintestinal manifestations present? Do we have postoperative prophylaxis we're concerned with in Crohn's disease? Is it a newly diagnosed patient? And mostly as well, we have to put into perspective, what is a patient's prospective prognosis? When looking at the agents directly, we have different indications, if you would, and efficacy based upon different treatment findings. Luminal Crohn's, fistulizing disease, mild to moderate UC in the outpatient arena, whether the patient is hospitalized. In pregnancy, we have data, for example, certolizumab pegol does not cross the placenta. And then extraintestinal manifestations, what's the data we have? So we now have 3 FDA-approved agents for Crohn's disease: infliximab, adalimumab, certolizumab pegol. They're effective for induction and maintenance of therapy in patients with Crohn's. There's no comparable trials, well done, large, comparing these agents one to another. The toxicity is very similar to the agents. Indications and delivery routes differ. The registration trials are well known to many people in the audience. The ACCENT-1 trial, randomized double-blind maintenance treatment for those who had responded to a single dose of infliximab, was positive. This was one of the registration trials. The CHARM trial for adalimumab, randomized double-blind treatment trial, large number of patients responded to adalimumab induction therapy, again led to the registration of adalimumab. And then certolizumab pegol, the PRECISE-1, the PRECISE-2 trial. PRECISE-1 was against placebo. The PRECISE-2 was randomized double-blind treatment who had responded and had baseline elevation of CRP. They had an initial dose of certolizumab pegol. Again led to the registration of the agent certolizumab pegol for Crohn's. When we've looked at anchoring trials, and again we argue you should never do this, but again, the general efficacy remains similar, and there have been larger trials looking at claims databases that show similar findings directly in individuals treated with these agents directly. The key things we do are several things to get a good response, if you would, and achieve remission. We give a loading dose, then the appropriate maintenance dose for these agents. In ulcerative colitis, similarly, we have 3 FDA-approved agents that are anti-TNFs: infliximab, adalimumab, golimumab. They're effective for induction and for maintenance of treatment with ulcerative colitis. And there's, again, no comparable trials comparing efficacy of one agent to another that have been adequately powered and well done. The toxicity is similar, the indications differ, and the delivery routes. The agents are well known to this audience, I'm sure. Infliximab chimeric, golimumab, adalimumab are humanized. Again, the registration trials had been done. The ACT trials, the ULTRA trials, the PURSUIT trials, the efficacy comparably one to each other. The key is how well did they do against placebo, and one could argue what's the number needed to treat, but they're all effective therapies and they all have been used to treat patients with ulcerative colitis. We give a loading dose in these agents as well, and then we give a maintenance effect, and then we might do optimization of therapy, which I'll talk more about in the next several minutes. One of the key things we learned from many different trials that inflammation is critical to the efficacy of biologic agents. If patients do not have active inflammation, as was one of the trials, the SONIC trial, for example, those patients that had active inflammation had lesions compared to those with no lesions did better overall with regards to the benefit of the agent. And it makes common sense that if you treat someone who has inactive disease with an agent that's effective for the disease, it's not going to work, whatever that agent is, whether it be biologic or other agent. The contraindication and the safety are critical points when we treat with any particular agent directly. We look at individuals. Do they have tuberculosis exposure in the past? So these are things we need to look at prior to the introduction of the agent. Hep B reactivation can be associated with liver failure. Congestive heart failure, class 3, class 4, based on the Chung data, was associated with a higher mortality. Demyelinating disorders, lymphoproliferative disorders, these were excluded from the trials, but there is perceived to be a higher risk, so one could argue, based on the data we have, how high that risk is. And other reasons directly. Serious opportunistic infections are seen in patients as well, so screen for these and do surveillance while they're receiving therapy. If someone is on, for example, an immune modulator and an anti-TNF and corticosteroids, one might use prophylaxis against pneumocystis. But again, be careful in areas where histo and other opportunistic infections are present and do careful monitoring, so these are looked for if someone develops febrile illness or lung-related symptoms. What do we do? So to minimize this risk, we look for TB prior to initiation, chest x-ray, PPD, a gamma release assay directly. If they're immune compromised, these can be negative. Exclude active infection prior to the introduction of these agents directly, an abscess, C. diff, CMV, check Hep B serology, and do the vaccinations. And the vaccinations are evolving recently. This is from the CDC. Of course, you can't read this, but just to say it's downloadable, and there's different strategies directly, and I'll take out some of these directly. So check titers in the office if you're unsure if an individual's been exposed. MMR, varicella, Hep A, Hep B. Vaccinations to give to specific groups regardless of the immunization status. Tdap, HPV, influenza, Hep A, Hep B, meningococcal in the correct individual. And then those that have potential live virus, the MMR, varicella, zoster. These are agents, again, that you need to consider inappropriate in individuals that have active treatment with TNF therapy, though we now have a dead quote, if you would, or an inactivated varicella zoster vaccine that is now available, just got FDA approval October 23rd. So this is something we'll be using probably in future clinical trials. With regards to immune modulators, we've used these for years. 1960s were the first controlled trials for azathioprine and 6-MP in ulcerative colitis. They're effective, at least we thought years ago that we're rethinking that for induction, if you would, based on some data I'll review. There's such that it takes a while till we gain benefit. And similarly with methotrexate, 8 to 16 weeks, they work as maintenance more for Crohn's, based on the data that Dr. Fagan has presented years back in the New England Journal. So if we look at these directly, a meta-analysis was recently done which showed truly that most evidence in azathioprine is such that it is not effective inductive agent for ulcerative colitis. And this has been looked at as well for maintenance, and it's not such that it's something that is well demonstrated to be effective. Early azathioprine in Crohn's. We have data from Jacques Cohen, Julian Panes. No benefit over placebo, the Aztec study. And in looking at another meta-analysis that had been recently done, in the Cochrane files, again, showed this is not an advantage over placebo when using azathioprine and shouldn't be used to treat active Crohn's as a primary modality. And there's really low-quality evidence that it's effective, more effective than placebo for maintenance. So the trials were not well done by today's standards, and it's critical to recognize that. The side effects have been problems that we had over the years: pancreatitis, bone marrow suppression, hepatotoxicity, and things of that nature. A risk of lymphoma I'll touch upon, and non-melanoma skin cancer is higher with antimetabolite use that persists despite cessation of the antimetabolite itself. A meta-analysis we published with many individuals looked at this, and the standard incidence ratio was about threefold. Those that were users had more of a risk compared to those that did not use drug. When you stop drug, the risk goes down to that of the general population risk. Men had a greater risk, double the risk of women, and ages under the age of 30 had the highest SIR, but the absolute risk was the highest for those over the age of 50. 1 in 354 patient years of follow-up per lymphoma. So 70 patients, 5 years follow-up, one gets lymphoma over the age of 50. Young men under the age of 30, the SIR was 9. So the highest SIR is for that group, but the absolute risk is the highest over 50. So methotrexate came into the limelight. It was around since the 1940s. Brian Fagan did the study, the landmark study, showing double the rate over placebo benefit for induction, and particularly was effective in steroid withdrawal. Maintenance, more so than placebo for a 40-week trial, benefit over placebo. The COMMIT trial, again Dr. Fagan published, did not work to show those on steroids initially given combo therapy with the agent were no more effective than placebo to be in a state of remission. But the levels were higher, as you can see here, of infliximab, and this is something that it reduced the antibodies against infliximab as well, and that's really one of the key take-home messages we learned from this trial. For ulcerative colitis, no benefit orally based on the data from ORAN. From one of the studies, the METEOR study, no benefit for those that were steroid dependent, but those who were off steroids, there was a larger percentage of patients that had withdrawal from therapy that was fewer compared to those that were on placebo, or more withdrawal was possible. So those benefited that were not on steroids per se. The issue with methotrexate we all recognize: nausea, vomiting, bone marrow suppression, hepatic fibrosis. Now with FibroScans we can circumvent that use, and it's relatively uncommon that we see cirrhosis. It's more those that consume ethanol and are obese that have the highest risk. Optimization of anti-TNFs has been a lecture into itself. Over many years, we've learned the pseudo-failure for symptoms of active disease. When we have inadequate drug levels, it could be due to anti-drug antibodies, rapid clearance, or inadequate dosing. And there may be a pharmacodynamic effect where there's a resolution or resistance evolves over time to the anti-TNF itself. So these are things that over time we don't understand that as well. To optimize the therapy, we give an adequate loading dose to the individual. We might give it in combination to boost the levels. It's equally effective, perhaps, based upon data from Jean-Fred and from Steve, showed that high levels in patients that were treated based on retrospective review of the SONIC data, if you would, those that had high levels did equally as well on combo therapy. So this is something we've taken from that, and future trials will look at that directly to see if that is indeed the case. If not, given in combination, then you want to do rapid optimization in an effort to gain levels perhaps that are appropriate or treat aggressively. Is proactive level monitoring appropriate? Well, this is an area that's evolving. We've had large studies to date, too, that have not shown clear advantage at the primary endpoint studied, but these are things that are now in evolution. And this is data from Adam Chaffetz and his group, that those that had levels monitored, that had levels over 5 with infliximab, did better than those that did not have monitoring, or those that had low levels, less than 5 if you would. And then Bill Sanborn published this retrospective review showing we can do reactive therapeutic monitoring, showing that individuals that have antibodies present are those that should stop drug. Those that have antibodies that are not present and have low levels can either increase the dose or shorten the interval. And then there's different variations on that as well. With low-level antibodies, you can overcome that, though that wasn't looked at in this study. So why do we give concomitant therapy? We want to lower the rate of infusion reactions, the rate of anti-drug antibodies. We get higher drug levels independent of the antibody, and then there's also lower rate of loss of response. And the SONIC trial itself, you look at the rates of infection, they were lower in those that had combination therapy. So this is something that is saying better control of the disease leads to better overall benefit with less infections. The drug levels in the SONIC trial, 3.8 versus 1.9, and these are clearly beneficial that you can raise the levels. The commit data as well showed that, other trials as well. The SONIC combination trial, overall you could see the healing of the mucosa and the withdrawal of steroids with achieving clinical remission, a corticosteroid-free remission, was superior with combo therapy, as was in the SUCCESS trial, the treatment of combo therapy for active ulcerative colitis. The mucosal healing data, 43.9%, 62.8% in ulcerative colitis with the SUCCESS trial. So again, an added benefit for combination therapy. Antibody production. Maria Abreu published data with Andres Yara retrospectively suggesting that individuals that are treated with azathioprine do not have to have full-dose drug to prevent antibodies, and this looked at 6TG levels above 125 was suggestive that it's less immunogenic, hence not as the same as 2.5 mg per kilogram, but lower. And then recently we've started to prognosticate for patients. We look at individuals that have risk stratification initially, clinical factors, serology, endoscopy, high and low risk we stratify, and treatments may vary. The AGA, clinical pathways for ulcerative colitis, we've put low risk and high risk, and depending upon the factors that are present, we can say these are the individuals that we would treat aggressively up front with perhaps combination therapy. The low risk, again, for Crohn's, and the high risk for Crohn's, based on the age at diagnosis, anatomic distribution, perianal disease, prior surgical therapy, or stricturing or penetrating disease. And recently, the concept of treat to target has evolved. Predefined goals of therapy we need, regular assessments, just as in diabetes, hypertension, we monitor the glycosylated hemoglobin, the blood pressure, if you would. Subsequent adjustments based upon therapeutic consequences, early intervention, and does it improve outcome? And yes, we believe it does, based on some recent data, which I'll present. So we want to realize that symptoms alone are not adequate. We set the goal, we're perhaps proactive in monitoring, not reactive, and we don't just start the medication, we optimize it directly. And this is the CALM trial, recently presented, and Jean Fred is the PI on this, and it's in press at this point in time, a prospective multi-center open-label randomized study treatment strategies of usual therapy looking at symptoms and also CDAI versus looking at biomarkers, CRP, calprotectin, and looking at the endpoint directly. And there are 4 different treatment strategies involved, but the fine point is that the primary endpoint at week 48 after randomization was Crohn's disease endoscopic index of severity less than 4, and no deep ulceration was substantially better in the treat to target versus the clinical management. So this argues for a treat to target approach. Other parameters as well were improved. Deep remission, biologic remission, mucosal healing, and other trends were seen as well, favoring the treat to target. So if we look at this in aggregate, we've learned a lot over years. When I came out of training years back, we always had said if patient has steroid-dependent disease or they've had steroids, the next step is azathioprine, back in the early 1990s, if you would, 1980s. But we now recognize azathioprine is not effective inductive agent for ulcerative colitis or Crohn's in aggregate when looked at trials. Everyone may have individual cases where they've seen where it does work, but that's not the data we're looking at. It's more the clinical trials and the aggregate data. Methotrexate is ineffective inductive agent for ulcerative colitis. It works for Crohn's, but there's not been back-to-back biologic versus methotrexate directly to date. We don't have any trials looking at that. We always consider combination therapy in patients because we get more efficacy, if you would, based upon higher drug levels we find in patients, but the combination therapy from the SONIC and the SUCCESS trial clearly showed benefit, but it's always what's the risk to the patient? Is the risk to the patient too high? Is it inappropriate? Over the age of 50, think twice, but if someone has short gut, is over 50, has no other options, this might be a scenario to do and maybe continue for a period of time, then taper off. The risk of lymphoma for azathioprine comes about after 2 years based on all the studies we have in aggregate. So over 2 years' time is a time frame you have to see, or over a year you start thinking, should I withdraw therapy? We load the biologics appropriately. We don't give episodic dosing. We treat the active infections before the biologics and vaccinate patients accordingly in an effort to truly minimize the potential adverse events, and then use a treat-to-target approach. Thank you.